The new world of healthcare is going to be accountable, it's going to be efficient, and it's going to be affordable. And we're going to talk a little bit about that tonight. So what we're going to talk about today is the Affordable Care Act. And the focus of the talk, I'm not a politician, I'm not a Republican, I'm not a Democrat, and I'm not going to talk about computer glitches and all the horrible things. I'm going to try and focus on the intent of this law and the intent of the good it should be doing and the good that I believe eventually will come out of it. It may take years. This is a radical change in the healthcare system, and there's been a lot of good that has come out of it already. And the good, I believe, is for all of you. I think the good that's coming out of this is really for the patient, and that's really what's, as a physician, to me, that is what's most important. That's what's most important to everybody here at St. Vincent's. So what I want to start off with is why. Why did this happen? And the reason this happened, you really have to, I'm going to have a few slides on economics of this country and healthcare economics. And the key word here is unsustainable. And I'm going to show you some graphs. The trajectory of healthcare in this country is unsustainable if it keeps going and we don't do something about it. We're just simply spending too much money on healthcare. And that too much money doesn't necessarily translate to better health. And that's a very important concept that underlies all of this. We are spending more than 17% of our GDP on healthcare, unsustainable. Our Medicaid programs, you may or may not know, Medicare is a federal program run by the federal government. Medicaid is run by states. It's a state program. So the way we run Medicaid in Connecticut is different than the way they run Medicaid in New York. That's unsustainable, and we saw that very recently in the state of Connecticut. For those of you who followed the hospital state budget cuts, the state of Connecticut, to balance their budget, cut $550 million from the hospitals in the state of Connecticut. St. Vincent's share of that over a period of 2.5 years was $30 million that they just said, you're not getting. And that's the money that we use to take care of people who are on Medicaid. Unsustainable. And the continued transfer of course to employees and consumers. For those of you who are in the workforce, you know your deductibles are going up. You know that you're going on to bare bones plans. Some people have $10,000 deductibles. You know your co-pays are going up. You know your co-insurance is going up. It just doesn't make sense. The system's broken and something had to be done. So if you start to look at the expenditure in healthcare in the United States compared to the rest of the world, you start to see that we're out of whack. This is some countries that you should know: Switzerland, Canada, Sweden, United Kingdom. And you can see that this goes back to 2005, but our expenditure is higher than most of the rest of the world. This is just another way of looking at it. When they divide it up between private and public insurance, you can see that most of the rest of the world, health is funded by public insurance. It's funded by taxes. Right? Like Canada, we all know about the United Kingdom, we all hear about socialized medicine. That is the way most of the world works. The United States is the only country in the world where health insurance is funded through employment. Okay, no other country does that. So we have a very large private sector that funds health care. And you can see how out of whack we are to the rest of the world. What this graph shows you is when you look at age down here and you look at the money we spend. The money in the United States is being spent on the elderly, people over 60 years old. So for younger people, our spending on healthcare is pretty much the same as the rest of the world. But we know that we do put a lot of emphasis on life, and rightfully so. And I'm sure we have all had friends, relatives, people we know who have spent a lot of time in the hospital at an elderly age, possibly in the intensive care unit. And unfortunately, possibly, that doesn't always work out so well. But you can imagine what goes into taking care of people like that. And that's where the large expense in healthcare in the United States comes from the elderly, but not necessarily, that doesn't necessarily happen in the rest of the world. The key part of this is how much you spend on healthcare does not necessarily mean you're getting better healthcare. So spending does not equal quality. So quality is very hard to measure. Okay, how do you define quality? It's very hard to define, but you kind of know it when you see it. It's one of those things. The intent of all of this is to become more efficient in how we deliver health care and to eliminate waste. How many of you have gone to a physician they ordered a CAT scan, and then you end up at another physician's office and they repeat the study. Or you get blood drawn, and then a week later you go see another physician and they want blood drawn again. That's just waste. Okay, and those are the type of things because we're not very well connected. So if you think about, we need to be better as a healthcare system at following guidelines. So if you go into a doctor with low back pain, one doctor will send you for an MRI, one doctor will send you for a physical therapy, and another doctor will send you to a neurosurgeon to get your back operated on. And it doesn't make any sense. It could be the same patient, and depending where they end up, they get pointed in a different direction. So care paths would be, well, if I'm a 65-year-old patient and I have back pain and I don't have any leg weakness or any numbness, don't need an MRI, I should go to physical therapy, and everybody should do that. And it's an example of what a care path is. Less costly sites of care. That's what this building's all about. Hospital is a very expensive place to take care of patients. Your home is the cheapest place to take care of patients, and everything in between is in between. Okay, we need to be better coordinated. We need to have increased access so you don't have to wait, so you can get into a doctor when you need to see them. And it needs to be more predictable. And we need to decrease the waste. We need to stop provider errors. We make mistakes in diagnosis. Doctors do, believe it or not. We make errors, infections, errors, safety errors. And we're going to talk a lot about safety in a while because that's really what St. Vincent's is known for. Unnecessary care, that's the patient with the back pain that ends up getting their back operated on when they could have gotten better with physical therapy. It's the doctor from Louisiana who is now in jail for putting cardiac stents into people who didn't need them. I don't know if anybody saw that news report. That's not good. Okay, readmissions. I was talking to a member of the audience who told me that they spent 5 weeks here over the summer and was readmitted 3 times. That's not good. I want to hear more about that. Okay? Avoidable conditions, lack of care coordination. We need to increase the value, decrease the waste. Estimates suggest that as much as $700 billion a year in health care really don't improve our health outcomes. Okay? It needs to be done differently. We need to practice medicine differently. Affordable Care Act was passed into public law March 23rd, 2002. Some people call it PPACA, some people call it ACA, some people call it healthcare reform, some people call it 2,000 pages of mumbo jumbo. Okay? Some people call it Obamacare. Okay, do you know that a poll was taken about 2 months ago, and about 10% more people were in favor of the Affordable Care Act than they were of Obamacare. First line, provide affordable health insurance to uninsured Americans. What that really means is a minimal standard of coverage at lower out-of-pocket costs. That's the intent. Doesn't necessarily mean that has happened, but that was the intention behind this law when you actually go through it. Reduce the growth in healthcare spending. A term we use is called bending the cost curve. Okay, make it less expensive for healthcare. Empower Americans, empower all of you to give you more say and more choice in what healthcare options are best for you. That's hard because it's complicated, and part of the reason we're here today is to educate you so you actually start to get an understanding of this. It's going to take you're not going to figure out Affordable Care Act in 1 hour. You have to keep working on it. We want to improve, the intent of the Affordable Care Act is to improve access to care, coordination of care, quality and safety of care, and the patient experience, the patient's satisfaction with health care. That's a tall, tall order. Okay, again, this is the intent. Doesn't mean it's necessarily happened. I'm not saying I'm for this or against this, but this is the intent of the law. And this is a very important piece, is you can no longer deny health insurance for a pre-existing condition. That's huge. Child with cancer, when they grow up, because most childhood cancers are cured, when they grow up, they cannot be denied health insurance because they had cancer when they were a child. And that's the way it was. That's not the way it is anymore. These are the things that you read a lot about. It's hard to understand. I'll go through it. They're factual. Again, I'm not saying I'm in favor, I'm not in favor, but they're factual. By 2014, January 1st, less than 2 months from now, all non-exempt Americans will have to have health insurance or face a tax penalty. Okay, everyone knows that. That's kind of in the news. Most people who have health insurance can keep it. Okay, and I'll show you that in a minute. If you have Medicare, and I can see there's a number of people in this room that have Medicare, keep it. Don't get rid of it. You're good. 80% of people are fine. It doesn't affect them. Okay? Young adults, this went into law a couple years ago, can stay on their parents' plan until they're age 26. That was part of the Affordable Care Act. The marketplace, that's the marketplace, and some of these things are in color are new terms, and that's why I bolded them. The new health insurance marketplace, that's where you buy the coverage. That's what Health Access CT is all about. That's the insurance exchange. Okay, and I'll come back to that. These are the tax penalties. If you decide not to buy coverage by January 1st, 14, you must pay, if they can figure it out, an annual fee of $95 an adult, $47.50 a child, or 1% of your income with a family max of $285. Now, the IRS has to figure that out, and my understanding is that's becoming a bit of a problem, but that's the law. There's no annual or lifetime limits on coverage. Every once in a while, you hear about somebody who gets, their Medicare benefits are done, right? That's done. That doesn't happen anymore, even for Medicare. And if you're small business owners, this is just a nuance, but companies with greater than 50 employees, you must offer job-based health insurance, or else there are other fines that you need to pay as an employer. And if you have less than 50 employees with average salary less than $50,000 of those employees, there is a special marketplace that you can go on to fund your employees' insurance if you choose to do so. 80% of people are unaffected by this law. 14% are clear winners. They're uninsured, and they can gain access to something that they should theoretically be able to afford because of their income level. 3%, there's probably no real consequence. They may have to buy a new plan, but price-wise it's probably similar. And then there's 3% of the losers. They'll have to pay for a higher quality health plan. They'll have no annual cap, and the 3% are going to get hurt financially. So when you actually think about everything you read and all the people who are arguing about this, it's not a lot of patients arguing about this. It's employers, it's doctors, it's healthcare administrators, it's government officials, Republicans, Democrats, but you're not hearing a great amount from the general population, except how they're, perhaps how their political, whatever their political party might be. What are the unintended consequences? You've already brought a lot of them up, okay? Some employers are incentivizing employees towards the exchanges. So the rule is that your full-time employees you have to insure. Full-time is defined as greater than 30 hours. So what are employers doing? They're building a part-time nation. Hire lots of people at 29 hours a week. We don't have to insure them. Okay, that's not in the law. That's what employers may choose to do. That's an unintended consequences. Lowering the number of work hours. Capping the annual benefit for their health insurance. So saying, okay, we'll pay this much money, the rest is on the employee. That's happening a lot. We're seeing very high deductible, bare bones plans. Anybody here work for GE, General Electric? They have a very high deductible, bare bones plan that they put into place, which saves General Electric billions of dollars. Again, doesn't say anything in the law to do that. That's just the response. And probably that would have happened anyway. Why? Because healthcare costs are unsustainable for employers. They can't, these costs put people out of business. Okay, you get one, if you're an employer and you get, or if you're a health insurance company and you get one patient who needs a liver or a heart transplant, that's devastating. Young, healthy adults may decide to gamble, go to Foxwood, avoid the exchanges, and accept the penalty. So what that happens is you end up with chronically ill, unhealthy people in the exchange. You don't have the young, healthy people to subsidize it, so the costs start to go up. Okay, that's what could happen. That's actually not happening. I'm surprised. I thought this was going to happen, but it's not happening, which is good. Young people are signing up. Okay? There's going to be a widening gap between, we have a doctor shortage in this country that's growing. 11,000 people a day going on to Medicare, not enough doctors to take care of all those people. Now you're going to start insuring everybody. This happened in Massachusetts when the laws went into Massachusetts. You start insuring everybody. There's not enough doctors. And plus, because of those laws, half the doctors left Massachusetts. So there's not enough providers to take care of all these people that we're now insuring. That's a big problem, okay? And this, it's not so much of a problem in this area because we got plenty of doctors. But you start going out into the Midwest and some of the more remote areas, that's a significant problem in this country. And someone asked me a question before about hospital revenue. Because there's a shift of patients out of the hospital, hospitals are seeing decreased costs. So what you're reading about a lot are hospitals laying off employees. Because less patients, less volume, less CAT scans, less lab tests, less X, Y, and Z, you don't need as many employees. Hospitals across the country, healthcare jobs are going down for the first time in a long, long time. I expect that's going to rebound as more and more people age and get into the group that needs healthcare. What's really happening is the hospitals are laying people off, but there are jobs in that outpatient sector. So the whole healthcare job market is shifting out of the hospital into the community. So an exchange is the marketplace. It's where you go to buy insurance. It's when you go onto the government website and they tell you it's not working. That's the exchange. It's just a marketplace. It's like a online store, okay? Or you can go, I'll tell you where if you're interested in doing this in Connecticut, Healthy Access CT has places that you can go to where they will help you sign up for the insurance, okay? So if you look over the years at the Affordable Care Act, provisions have been put into place 2012, 2013, 2014, January 1st is the big one. This is the year where 19 provisions out of all of them are being put into place. The biggest one of all those, the reason for all this controversy that's now in the world is this, the individual mandate, the fact that you have to have health insurance. That's what this is. That's the big controversy now. There's so many other things in the Affordable Care Act, right? Nobody's arguing about pre-existing conditions and saying, oh, we shouldn't insure, well, maybe the insurance companies, but no one's saying we shouldn't insure a child who had cancer, right? That was seamless. But this one, the individual mandate, is really, has generated a lot of passion in a lot of people for obvious reasons. Same way when when the government bails out General Motors, there's people for it, there's people against it. How involved should the government be in people's lives? I mean, that's really what a lot of this controversy is all about. So the crux of the talk is, what should you expect as a patient? How is healthcare going to change for you? And this is where I'm going to start to focus on St. Vincent's a little bit, because my job is to position St. Vincent's to take care of you in the context of the Affordable Care Act. And so to pull the good things out and bring that to our patients. Expect to be empowered as a patient. More involvement in choosing your healthcare plan. We talked about that. You're going to become partners with your providers. You're going to become partners with your doctors and starting to make decisions and become more empowered so that you're just not doing what they tell you to do. That's the intent, okay? You want to have increased access to reliable information. You should have more information on quality. You should know the quality of your healthcare system. You should know the outcomes of your healthcare system and your doctor, and you should know the patient experience. You should know, for the patients who come to St. Vincent's, how many of them are satisfied with their care. And I'll show you how you can get some of that information. You should have the ability to go online and look at your medical records. Okay, that's part of the Affordable Care Act. Access to your medical records so that the doctor's not looking at them and you don't know what's written in it. And you should have access for advanced directives. We should know, remember I talked to you early on that most of the care and most of the money spent is on the elderly, and often that's in the ICU, and a lot of times that's a bad outcome. We don't really know, for most of those patients, did they want that care? And this is a really hard subject to talk about, and doctors don't like talking about it. But my advice to all of you is to have a conversation with your loved one, have the conversation with your doctor, and somebody should know what your desires are. Do you want for us to do everything humanly possible to keep you alive or not. And there's lots of things in between. That's called an advance directive. So expecting quality, safety, care coordination, attention to your patient experience. Part of the law is increasing prevention and wellness. So if you think about health, we don't really have a health system. We have a sickness system. We take care of people when they're sick. We don't keep them healthy. So in the law, it is written, and this may be the crux of your question about Medicare, but you should have free annual wellness visits. There should be no-cost screenings for diabetes, high blood pressure, heart disease, cervical cancer, mammograms, bone density tests, and flu vaccine, and about 70 other items that there should be no cost. That's written into the law, and that's a baseline status. Federal funding for expanding Medicaid for prevention and wellness is in the law. Volume-based to value-based care. This is a great concept. I like this. This is what I like. Right now, doctors get paid for everything they do to you. Remember we talked about less could be more? So if I'm a pancreas surgeon, I operate on you, I get paid for that. If you have a complication, you're bleeding, and I take you back to the operating room, I get paid for that. If I put a line in your neck and I puncture your lung and you get what's called a pneumothorax and I have to put a chest tube in, I get paid for that. That's the way the system is. It's per click. The more I do, the more I get paid. The more complications you have, the more I get paid. That makes no sense at all, does it? It's a perverse system. We want to switch over the next, I don't know how many years this is going to take, but the whole payment system has to change to fee for value. We have to get paid for your outcomes. If you're a diabetic, I shouldn't get paid if I checked your hemoglobin A1C level. I should get paid because I prevented you from going blind or losing your leg. Population health, I'm going to talk about. Population health is how do we take care of people across the continuum from conception to death. Taking care of patients across the continuum, not in silos. Innovative patient care programs. I'm going to touch on some of these. These are new terms that you're going to hear about. Clinically integrated networks, accountable care organizations, patient-centered medical homes, high reliability organizations. These are all the new terminology that you need to be looking for when you choose a health system and a doctor. Because that means if you walk into an office and you see something called patient-centered medical home, that means that that office has been certified to take care of chronic illnesses. They've met criteria that's shown that they can take care of a diabetic patient and do what it needs to, or a patient with COPD, lung disease, to do what they have to do to keep them out of the hospital. That's the goal, keep people out of the hospital. Expecting improved care coordination beyond the hospital walls. That's what you should expect. So there's a lot of community doctors who are part of health partners. It's kind of a joint venture between our community physicians and our hospital. And I'm not going to get into the politics of who's in and who's not. But you can see that they're all very similar. Accountable care, person-centered care, patient-centered medical home, high reliability organization. There's a lot of overlap here. The context is the care around you. You're in the middle, and everyone else has to be coordinated around you. The care should be at your convenience, not at my convenience. That's the intent. It's going to take us a while to get there. But if you're a patient of one of our doctors, I'll use Dr. Goldfarb as an example. Dr. Goldfarb's in St. Vincent's Health Partners. If you're a patient of Dr. Goldfarb's, and we'll know from Medicare, if you're a Medicare patient, as an example, we will know from the Medicare database if you got admitted to a hospital in Florida. And that's how we can keep track of what happened to you. It's a remarkable way to take care of patients. What are the expectations of your healthcare system? Your expectations when you walk into a hospital should be, number one, don't hurt me. Number two, heal me. So don't hurt me. Don't make me worse than when I came in, right? Heal me and be nice to me, right? You don't want them to be nice to you at the sacrifice of you getting hurt. You should expect to be cared for and be in a place or in a doctor's office or in an urgent care center or wherever it may be, whether it's in Connecticut, whether you're vacationing, it doesn't really matter. You should expect to be cared for, and that's built in inherently into the Affordable Care Act. It doesn't say in the Affordable Care Act that it's the law that you have to be cared for, but it's in there. And we know that when it comes to your health care that you do have a choice. And in conclusion, I would just like to thank you for coming out tonight and choosing St. Vincent's for this talk.